Hi, I'm Catherine Pope. I'm a medical sociologist at the University of Oxford, and I'm a social scientist, not a doctor or a nurse. And I don't really do research about smoking cessation or behavioural interventions. Although a while ago I was a member of the independent team who helped review the research evidence to support the legislation around plain paper packaging of tobacco in 2016 that made us, I think, the UK the second country in the world to require cigarettes to be sold in plain packaging. But most of my time is spent doing research about the NHS, UK National Health Service. And in particular, I look at what health professionals do. And some of my work has been looking at emergency and urgent care call centres and how they use computer software to help assess and triage patients. I thought I'd share with you just a little of the preliminary work about breathlessness that we're doing to support the response to the COVID-19 pandemic. Many of my colleagues in Oxford are family doctors, or GPs as we call them here. And because COVID-19 is so contagious, many of these frontline staff are having to quickly learn to use video technologies to consult with patients. In this pandemic, the way the NHS works has changed dramatically. For the first time since 1948, you can't just walk into a general practice and ask to be seen by a doctor. This shift to video consultations is the fastest and perhaps the most radical service innovation the NHS has ever seen. And one of the questions that GPs have asked us is, how can we ask about key symptoms of COVID-19, like breathlessness, when we're not in the room with the patient and we can't use any of the face-to-face cues or any of the tests that we might normally have to use? In response, we're planning some qualitative research using interviews with patients and staff and detailed analysis of some recorded video consultations to try to figure out how we can get doctors to ask the right questions so they catch the cases of COVID-19 that are serious or about to become so. There are some standard questions that assess breathing, and colleagues here in Oxford have been pulling together rapid reviews to see what the evidence is about the best questions that can be used. And if you look up COVID-19 Evidence Service, you'll find a collection of reviews that the team have done. But their rapid review of assessing breathlessness found that there were no validated tests for assessing breathlessness in acute primary care. And there's no evidence that attempts to measure respiratory rate over the phone, for example, would give an accurate reading. So what they've advised doctors to do at the moment is to ask patients in video consultations to describe the problem with their breathing in their own words, and assess the ease and comfort with which the patients reply. And this means asking perhaps open-ended questions like, how is your breathing today? And really listening to what the answer is. They also recommend some questions derived from an NHS symptom checker that has been user tested but not formally evaluated. And these are questions like, are you so breathless that you're unable to speak more than a few words? They suggest too that a focus on a clear story of how the symptoms have got worse and the patient has deteriorated are important. So a question like, what makes you breathless now that didn't make you breathless yesterday, can be helpful. And they also suggest that breathlessness always has to be interpreted in the context of a wider history and physical signs, if you can get those as well. There are a number of scores and diagnostic tests out there that are being tried, but some of those don't seem to work very well. And clinicians are trying smartphone apps and sometimes these Fitbit type things to help build up a clinical picture. And again, the evidence for those in terms of whether they work or whether they're safe is lacking. So my job over the next few days is to pull together a research team who can help improve remote assessments of breathlessness. We're trying to examine what frontline staff are doing, what works, and crucially, what doesn't work. And we'll use our qualitative research skills to help doctors ask the right questions, to get the answers, to help them make decisions that will ultimately save lives. We've got to go through ethics review before we can officially start, and we're hoping we can begin work very soon. I didn't really think that my skills in qualitative research or medical sociology would be immediately useful in a pandemic. Turns out I might be wrong. I hope we can do this rapid research to help frontline clinical staff assess breathlessness. And I thank you for your time and for inviting me to participate in your Breathe lecture series. I hope it goes really well, and keep up the great work that you're doing.